morning, everyone, and very excited to have two speakers with us today. And they're a very unique theme for World Sight Day. And both these topics and subjects are so important to address because we see these patients who have low vision but are not quite able to cope with studies, and they also have systemic features sometimes. So it's very difficult to distinguish whether that's stemming from the fact that they have low vision or whether it's from the fact that they actually have an intellectual disability related syndrome. The other aspect that we deal with also, and probably are not able to address to the fullest, is the mental health burden of living with chronic and debilitating eye disorders. So, what is the impact of that on the mental health of the patients and how they are doing psychologically at that assessment? So, to begin with, we have Professor Praveen Suman. She's the director, Child Development Clinic in Institute of Child Health at Sir Ganga Hospital. She's also a member of the Technical Advisory Group of Research Projects and guides the thesis of many postgraduate and fellows. She's the core member of the Inclin Study Group and founder member and president of NGO for Special Needs Children Sarthi Support Society. She's the founder and director of Child Development Clinic and Vicura Child Development Services at New Delhi, as well as the Post Director for Fellowship in Development and Behavioral Pediatrics under the aegis of Indian Academy of Pediatrics at Sir Ganga Hospital. She's been awarded as the Ruler of the Year 2023 by the Delhi Medical Association. We are very honored to have you, and with that, I'll hand over the stage to you.
Good morning, everyone. Good morning. On this special day, it's my pleasure to be here amongst you on a special day of World Sight Day. I think it's the 9th, but we are celebrating today. And it is, so we'll be discussing, and I thank all the organizers and especially Dr. Shailaja for inviting me here and interact with you all. So today we'll be talking about certain developmental issues. As we know, development and vision go hand in hand, glove in hand. So for every child, we need to have a appropriate and good vision. Then only child can develop properly. So we'll be taking few cases. Let's talk about vision and child development. As we know, vision guides our movement. It facilitates social interaction and leads to recognition and understanding of the environment. Without vision, we cannot develop all these skills. So, any deficit in visual processing or in cerebral visual impairment, it can lead to deficit in not only motor, cognition, as well as social development, which may mimic certain developmental disorders like autism spectrum disorders. So, being as an ophthalmologist, you know more than me about the ocular problems and the CVI. I'll be talking more on autism and their interrelation, and then we can probably discuss also. It will be good if we interact more. Similarly, children who appear primarily affected by cognitive and social development, children who come with mainly autism, may manifest a lot of visual and perceptual deficit that may be contributed to their disorder. So it is a dual relation. This dual perspective highlights the need for link between the impaired vision and neurodevelopmental disorders to be identified appropriately and early so that early intervention makes all the difference, as all of us know. So I'll be showing 2-3 videos, and I would ask for your inputs to what all you can see and what was actual presentation. Let's see this video, first video. So this is a 4-year-old child who presented with developmental delay. Child was not responding to commands, child was not interacting, does not recognize the parents, does not follow the instructions. But on examination, you can see, and I would like you to tell me what all you could see in this video. Anyone?
Eye contact.
Yes. And he was too much busy with, and anyone else?
Too focused on one thing, that focusing that, there's the abnormal focusing on
On
a
the object,
on the
yes.
object, which is inappropriate for that age.
Yeah. And the way he's looking at the
Yes,
object.
the way he's, focused.
And he's watching the object so closely, he's just touching everything and he's just trying to. So there are some visual deficits as well, you can see. But majorly, we know for autism, which I'll be discussing it later on, I will be telling you what are the symptoms of autism which can be present. So as we can see, this child can mimic like visual problem as well as autism. Let's see this child. This is a child, 10-month-old child, now 10 months. This child came to me when the child was 2 months old, and parents brought the previous sibling had mild autism, which was treated, and the child is doing fine. And the younger sib, when born, had microcephaly and was brought to me for the child is not focusing on the face. Okay. So that time we suspected microcephaly and ASD-like features. And then we did the genetic evaluation. Then MTHFR gene mutation also came positive, which also predisposes the child for the autistic spectrum disorder. But the way child was reacting and interacting, I'll just show you right now. So he's getting therapies and all. But we could feel there is a visual impairment. So the child was evaluated for the CBI and there was impairment as well. Now child is getting treatment for that stimulation. But that's where the confusion, especially in younger children at 10 months. So because of that, child is not interacting with people, not following command, not responding to the name. You can see this video just. Okay.
Very interested, but
Very close, probably. Yeah. Anyone else want to?
he can't see, I think.
You can't see? पकड़ तो रहा है he's holding her leg. Not and he doesn't seem to be interested also, isn't he? Did you see? That's very important that he is not interested. The moment probably he is looking at the movements because the thing is moving, so he's appreciating the movements also. But as you keep the thing in front of him, he is not interested in looking at the objects. He's avoiding and looking here and there. So then comes the dilemma whether it is just autism or it is just a visual impairment or not. This is what we have to really look at. Let's see another presentation of, there can be different presentation. This is a behavioral presentation. Like this is a child who had visual. I'm technically, no, I need to build. So this is a child who is 2.5-year-old child who cannot speak and who had who was not able to see also. So this is how he's been communicating with the child. So any child in which so many behavioral problems are coming, then you have to think of underlying communication difficulties. The child has to communicate, he wants mother's attention, he's going and hitting the mother. He doesn't know how to talk, how to call her. So this is the way of the moment he starts beating the mother, she will either, start consoling the child or start shouting at the child. Somehow she will give the attention to the child. So whenever a child with significant behavior difficulties come, you must suspect these kind of problems. So for which we have to investigate. So these were certain few patients. So now I will talk about autism spectrum disorders. So how many of you seeing very commonly autism spectrum in your practice?
Very common.
Very common.
Not very
So because it has significantly increased these days, according to the latest statistics, 1 in 32 children has autism spectrum disorder. So if we do not understand these problems, we will not be able to pick it up. Okay. So the most common, and as I said, they can mimic like visual impairment, and which can be treated. We have seen.
Of the day.
Please make
Happy birthday. Happy birthday.
people on Zoom, please mute your
अभी तो फोन
mics.
चालू है सर
ये भी ऑटिज्म का पार्ट है.
Digitalization has created more, and in fact, I would say this is one of the reason for increasing autism these days. We see children who are watching children as young as 1.5 year, 1 year old watching TV for 8 to 10 hours per day screen time. This is what is the scenario, so which is adding on to our problems.
Just reels. Reels are like totally disconnected, nothing to learn.
Disconnected.
Just
And you're not giving the social engagement, which is very, very important for child to learn. Every child has to see you. This is how your mirror neurons develop. You learn joint attention, you learn imitation, and that's make the child learn all the social skills and language development. So in children with autism, so I will just briefly describe what is autism, because most often we get confused. What is autism? कि अच्छा ये तो बोल रहा है, ये तो मुझे देख रहा है, so probably this child is not autism. So autism is not only speech delay, or autism is not only just eye contact. Autism is a problem of social communication difficulty and social interaction. There can be children who are intellectually very fine, very good. Like I have a child patient who is in class 10th and his IQ is 110. Probably he's the topper of the class. But if anyone is making fun of him, he doesn't understand that. So social skills, social interaction is equally important for a child to live in the society. In fact, more important than education. Okay. So in social interaction communication, there are 3 criteria. This is the latest DSM-5 is the baseline on the basis of which we diagnose whether the child has autism or child does not have autism. So it has a standard criteria. There is a level, there is part 1 and part 2. In part 1, there are 3 sub criteria, and child has to fulfill all the 3 sub criteria. First is social and emotional reciprocity. That means child is not able to talk. Very often children will come and they say, "ये तो बात तो करता है." But when if you go into the detail, does he come and talk to you by himself? Like school में क्या हुआ था, क्या वो सब नहीं बताता, बस अपना बोलता है. So that's called need-based communication. So these children they may or may not have good IQ. They can be speaking, but the social interaction, to back and forth conversation or initiation and sustaining a conversation is not present. Then there can be non-verbal communication difficulties. Non-verbal communication, communication has 2 parts. One is verbal communication, जो हम बात कर रहे हैं. Another is, in fact, more important is non-verbal communication. If I want something from you, even if I cannot speak, I will be asking, give. Okay? Even a 10-month-old child looks at the parent and start understanding the non-verbal communication. And if a child has visual impairment, child will not be developing all the non-verbal communication. So any child, if in early phases does not have a good vision, then it will affect not only the other skills, the non-verbal communication will also not be developed. Simple things like pointing. If a 1-year-old child comes, if we ask where is fan, he will say, it's fan. Is mama, hai na? So, or if he wants something, aeroplane, he will start sharing his enjoyment, everything by pointing. So this is called non-verbal communication. In fact, it has been seen till 16 months, a child should develop 16 non-verbal communication skills. So that's more important than the verbal communication. So any child who is not developing non-verbal communication, pointing and gestures, so we must suspect either autism or visual. Like we have to look for all these things. We keep on waiting, nahi kar lega. Some children are late, especially children who are born premature, who have some problem at birth. We have a tendency, not you, the pediatricians for sure, okay, let's wait. Kai bacche late karte hain. So there is nothing like that. We have to start the intervention at the earliest. Then the third point is creating and maintaining relationship. That means they do not know how to make friends, do not know how to maintain the relationship. I had a patient whom I diagnosed autism at the age of 23 years. He was never diagnosed. So he came with the problem of relationship problems. So it is so, I'm just giving an overview. Autism does not mean कि बच्चा बोलता नहीं है. Autism can be a very varied presentations. And then the second and important part is the abnormal and repetitive behaviors and interests, in which there are four sub criteria, but out of which even if child fulfills two of the criteria, that means the child can have autism. First is the stereotype speech and behavior. Stereotype speech, there is a repetitive behavior, there is echolalia, which you all are familiar with. Then child likes to play with the, with the same, like to line up the objects or like to play in a similar manner. So the basic problem in autism is this only. There is a problem that children are not interested in people, first point. And second is they like to follow a pattern. So these are the two important, just to simplify things, I'm telling you. They like to follow a pattern. And they are resistant to change. If there is a slight change in the routine, for example, Dr. Shelja comes from one route daily. If she changes, they get upset because that's what they are they want predictability. If there isn't something which changes, they cannot accept those changes and get upset very fast. And they have a fixated interest, and there can be hypersensitivity and hyposensitivity to sensory inputs, which I'll be just showing. So the sensory input can be different. They can be, for touch, they have difficulty. Some children who want a lot of hug, and so there can be hyposensitivity, at the same time there can be hyper. So every child can have a different sensory presentations, but sensory presentation, as I showed, is not the must. It may or may not be present in almost 30% of the children. So, but if it is present, a lot of children will come with the visual, I'll just show you the next slide. Okay. So what are the visual symptoms which will be useful for you to understand, because you'll be seeing more of visual presentations only. So visual sensory symptoms there can be hypersensitivity toward the visual stimuli. For example, they focus on tiny pieces. They will just picking a small thing, so they'll be like to play with the thread or something like that. They dislike dark and bright lights. There can be dislike for sharp flash of lights. They get upset. They are looking down most of the time. They are covering or closing their eyes or blinking or closing their eyes frequently. And there can be peripheral vision as most of the time you will see, especially the squint specialist, the strabismus specialist, the child generally comes with कि बच्चा जो है आँख के कोने से देखता रहता है, so whether the child has a squint or not. So that could be one of the presentation of the autism spectrum disorder. And there could be hyposensitivity as well. That these children have lot of attraction towards the light. They want to see all all the lights and all the toys with the lights and all. Looking intensely at objects or people. So, and moving fingers or objects in front of the eye. That's a very common presentation. Children with autism will be, they'll be playing with their hands or moving hands. And in fact, this can happen. I will be discussing CVI and all. So it can happen in visual impairment also. Children can have stereotypic movements, will have difficulties in interacting, will be looking at the things very intently because they are probably not perceiving it nicely. And there can be fascination and with reflection and or brightly colored objects. Okay. So I'm just discussing because when later on I will be discussing CVI, you will see there will be a similar kind of presentations. So I'm just letting you know the red flag signs of autism spectrum, which is present in less than 1 year of less than 1 to 2 years of old children. Because we should focus on early diagnosis and early intervention. We have seen that with early intervention, children can become fine, can improve. And these are the early signs. I'll go through the list, you will see these are similar to the visual impairment as well. For example, there is lack of showing, which I told you, pointing, lack of pointing, lack of sharing interest or enjoyment. There is repetitive movements with the objects. There is lack of appropriate gaze, lack of response to name, and lack of joyful expression, repetitive movements, lack of pointing. These are symptoms suggestive of autistic spectrum disorder in early. I'll just show you a few videos also, which are easy to, I think, understand. So this is, just see this page. Anyone? What can you see in this video, madam?
It's a block. Ideally, it should be used. It should be used in an appropriate way, but the child is focused on rotating it, which is like, it's not the
It's not the appropriate
way to do. Should be rotating it. Child is rotating it.
This is repetitive and stereotypic. So they do not know the functional usage of the toy. Okay, that's where the problem is. Child does not know how to play because he's not looking at people. He's not developing the play skills. Yes. Okay. And whenever the child is moving, this way you can see the body movements as well. That the way body is he's flickering the body hands. So these are certain other symptoms. So this is flapping and body tensing movements which can appear in children with autism spectrum disorders. Okay. This is another child who presented with global developmental delay. I'm just showing you videos so that you just get the idea of autism. And this is a child who initially had a speech, but later on the child has regression of the language milestones and child had midline repetitive movements. And as the toys are there, she's not interested in playing with the toys. She's just busy in herself. She's just putting the hands in the mouth and she has poor social interaction, no joint attention and no communication, no functional play, mouthing of toy is present. And then we did the genetic evaluation. Any child who presents with regression and of the speech and a girl with the midline skill deficits, then we must suspect MECP2 gene, Rett syndrome, which came to be positive. So you know all these things. Okay. Then comes the treatment. So you must. So you must be familiar with a lot of treatment. People must be coming and talking to you, especially those who are dealing with autistic children. कि मैं इसको sugar बंद कर दूं, इसका gluten बंद कर दूं, should I do this and that, and there are so many. अभी तो Trump has also given a verdict on certain drugs, leucovorin and all, for the treatment of autism. I think everyone is familiar with that. So let me just give you, these are the treatment modalities which are given by the FDA earlier, but now FDA has approved leucovorin, but still we do not have that data to suggest that it is effective. And these are various treatment modalities like antimycotics, secretin, immunotherapy, and a lot of chelation therapies and all these. But according to FDA, these are not recommended, should not be given to children. The only recommended therapy for children with autism is behavioral intervention. In the end, I will just show you what is behavioral intervention. And if medication, then risperidone is one of the medication which can be given for comorbidities and other difficulties. But rest of the therapies are only supportive, but the chelation and all these therapies should not be given. And stem cell therapy and hyperbaric oxygen, there are a lot of modalities which are going on in the society, and it is but these are not recommended by the FDA. So this was as far as autism was concerned. Just as far as cerebral visual impairment, as I've been discussing, you people know more than me probably, but I'll just touch few topics so that we can compare. So according to the latest studies, the in the cerebral visual impairment, the impending doom, it has been found that it is the leading cause of visual impairment in children in the developed countries. Okay. And a recent study from South India also noted that cerebral vascular visual impairment was the cause of visual impairment in 33% of cases, and CVI with ocular causes almost 11% of the cases. Another 11% of the cases. So CVI occurs due to the functional and anatomical abnormalities of the retrogeniculate visual pathways, including optic radiation, occipital cortex, and visual associative areas. So etiology, there is generally an underlying etiology in the form of asphyxia, periventricular leukomalacia, trauma, any perinatal events which leads to prematurity, hydrocephalus, meningitis, asphyxia, any these abnormalities, plus any infections, interventricular hemorrhage, connectrus, and along with genetic abnormalities and chromosomal abnormalities, these children are predisposed for the CVI. As I discussed the second case, in the small child, the MTHFR gene, where we were discussing about the autism. So the child has CVI as well. So this is a child with cerebral palsy with strabismus plus visual impairment. So the common presentation, straightforward presentation in these children is due to the visual concern, which you all know very well, that child is not looking at the faces, child is not tracking the people, not looking at self in the mirror, he is not reaching for the toys and tending to look at things close to face. And the child has tendency to seek noises on touch sensation. So I will just do it fast. So we have to screen all the children whom we have suspected that there is a problem. And so I will just wind up first. So these are the behaviors which we have to look for. This I will not go. So this all you are familiar with. And the goals of intervention for the goal for intervention in a child with CVI is definitely in phase 1, you build the consistent visual behavior by improving the vision, and then integrate the vision with the function in the form of support mobility if required, or in older children, there can be understanding, there can be reading problem, writing problem, so these can be done. Aim is to help them, make them independent. This is one of the second last slide. So this is a slide for the management of children with autism spectrum disorder. This is called NDBI, Naturalistic Developmental and Behavioral Intervention, in which it enhance the social. So this child came from UK and they were twins and the brother was fine, had mild communication difficulties and the sister had visual as well as autistic spectrum. So the child was treated for this and you can see in this we have to enhance the social interaction, we have to reinforce the social engagement. The moment the child is not looking at you, you stop reinforcing the things which she wants. Like she wants to hear the poem, but she will make an eye contact and then she start avoiding you. And the moment she avoids, you stop. So that the bad behavior should not get reinforced. She should understand I have to look at the people, interact with them, then only I'll get the reinforcement. So this is just to give you a glimpse. Okay, sorry. So in the end, I will just show you a success story of a child with autism who presented at the age of 4.5. So you can see he is not interacting, he is busy and he has body movements. And after treatment, Ram, Lakshman, Bharat, Shatrughan, so this child. So in the end, he got the trophy and he got the most amicable child of the school. So the children can improve provided we give them the appropriate and early intervention. Thank you so much.
That excellent lecture. Basically, where we have confusion is that many a times when children have everything normal, I mean, even the eyes are normal, looking normal, and we think probably there is some or it could be a developmental issue. So, how do we differentiate in clinic that this could be? I mean, the child is able to see, but there is probably the developmental issue or the not willingness to communicate that I'm able to see, because sometimes that happens. Everything else is coming normal in an ocular examination.
So as we have seen, ocular problems will be picked up in all 60% of cases, but in 35% cases, you may not have some other ocular problem. But a child who has a developmental delay, in that case, as you are seeing, there is a problem. We need to do the detailed developmental evaluation of the child, where we play with the child, we do the assessment in all the domains: cognitive, language, social, adaptive function. So that will give us an idea whether the child has just a problem with the social interaction, or the child has a global developmental delay, or the intellectual disability. So these are different entities where we have to evaluate the child, and during that we see where are the perception, how is the perceptual difficulties. And in older children especially, a learning disability, I would say, is one of the areas where it can mimic like a child has difficulty with reading and writing, but there could be underlying. So for that, we need a detailed developmental evaluation.
And one more, the opposite side of it, like children with low vision, because we see a lot of patients with retinal dystrophies and other hypoplasia. What kind of developmental issues they may develop because of the low vision?
So
that also,
as we say, development and vision go glove in hand. But if a child has a visual problem, he's not interacting, he's not learning from the environment, there is no social, emotional, cognitive, everything is getting affected. So this is as I showed in the initial day, this is a dual interaction. So a child who has a low development will not be able to do so well. On the other hand, the child who has a visual problem, definitely. A low vision is another. In fact, for blindness, you have a lot of things, braille and all, especially in older children. But the children who are partially blind, what you call, are the children who do not get much of the help. I think that's where we have to struggle, because they can see. I still remember a child who was studying in the school but he was not getting any help because he does not come in the category of typically developing children as well as not in the severe disability also. So the child is not getting help, but he needs help. He needs some, modifications in your visual apparatus or some, there are nowadays digital apparatus are available. You can give bigger screens where the child can have bigger words, and all those things can be done nowadays. There should not be a problem, but they will get the help only if they get the certification. So, do you think that there is a help for partially blind? Still, it's not there.
Partial for partially
Partial,
blind.
it's nothing.
They do get like 20%, 30% disability certificate.
But they will not have.
They don't get anything.
So that
Like if you lose one eye
Yeah.
completely, it's 30% disability and you don't get anything.
Yeah, that's very sad. Similarly, there is a term called borderline intelligence or slow learner children. Like normally IQ should be more than 90 and above. A child between the range of 70 to 90 who is slow but he will not get the help. Either the child will get help only if the IQ is less than 70 or if it is more than 90 and child has learning disability. So the borderline cases, I think they are the ones who are not getting help also. So this is where we are lacking.
So I have two questions. Like, do you like regression of milestone is also a part of autism? Like, if the child is doing good at the age till the age of 2, I have one children of retinoblastoma who like was having the normal milestone, and during the treatment after that, the child is like gone into this autism spectrum disorder wala thing. That stop
There is an entity. Am I करके answer करती हूँ?
regression of milestone is a part.
I'll just answer. So there is a entity called autistic regression, okay, which is present in certain amount of children. I think 3 to 4% of children. So it is a child is doing fine and then start regressing. So it is not that autistic regression is present in 100% of children. Yes, but there is an entity called autistic regression. But before labeling just autistic regression, we have to rule out other genetic disorders as well. As I showed you a video of Rett syndrome and other disorders. So if there is regression due to certain other disorders, these are special and different disorders. Now, earlier there was a terminology called DSM-4. Before 2013, there used to be a DSM-4 criteria for autism spectrum disorder, in which Rett syndrome also used to come under the category of ASD. But nowadays, autism is a special entity, is a separate entity, and Rett syndrome is a different entity. So whatever we are doing, because we have to go by the scientific literature. So yes, it can happen in few cases.
What is the risk of if the first child is showing the spectrum of autism? So what is the risk with the second child?
So, as I have not discussed the etiology in detail for autism happens because of the interaction of genetic and environmental factors. It is a multifactorial thing. So, in 20% cases, we do see genetic predisposition for children having autism spectrum disorder. So, any child who comes to you with the with the autism spectrum disorder has to be first investigated for all the there are whole genome sequencing these days or chromosomal microarray. So we have to investigate the child. After doing complete investigation and we do not find any reason, then even after doing complete examination, there are 7 to 10% chances of second child having the autism spectrum disorder. And a family where you have 2 autism spectrum, third child is 30%. Okay.
Thank you so much. Start with the next lecture, and probably after the first time people can ask more questions.
Thank you for the excellent lecture, ma'am. Next, we have Dr. Prerna Sharma. She's an associate professor of clinical psychology at the Center of Excellence in Mental Health Institute of Human Behavior and Allied Sciences, New Delhi. She's also in charge of training and supervision of MPhil clinical psychology students. And her research interests are youth mental health, trauma, self-harm, transdiagnostic health and psychosocial issues, public mental health, and palliative care. She has various publications and awards to her name. And with that, I'll hand over the stage to her. good morning, everyone. So disclaimer that I'm not a medico. Although I work out of an academic institute where neurology and psychiatry, clinical psychology, and psychiatric social work are integral part in treatment and diagnosis and management of various neuropsychiatric diseases and disorders. I have kept my presentation extremely simple. In fact, in simple language, I would say that I have dumbed down the concepts to understand or to take a pause and think about mental health that we usually don't have the opportunity to discuss. Maybe we think it's not very important in the face of when we look at disorders from a biological point of view strictly. But as a mental health professional and working in a neuropsychiatric setup, I would say that any disorder or any disease has psychosocial, biopsychosocial, cultural, economical, and political aspects to it. So, which we cannot ignore. So, to start with, I should have added that to begin with, but it just occurred, so I'll read it as it is. WHO's definition of health. Anybody knows? What is the definition of health by WHO?
Physical and mental well-being. Not merely an absence of disease, but physical and
Yes,
mental.
so it's not the focus. The disease is not the focus. Health and disease we cannot equate. Merely absence of any disease is not health. So I'll read it. A state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And this definition is it emphasizes on a holistic view and was given back in 1948. So the key components of WHO definition is physical, mental, social, not merely the absence of disease. Given this, the implication of definition is holistic approach, focusing on the quality of life and the dynamic processes in the disease that happens when we are treating any disease. So coming back to my slide, we do see patients with disabilities, whether it's intellectual or any sort of acquired disability or after stroke or any trauma to the brain or any developmental delay or autism, as ma'am has already established well for me, so I don't have to go through the same thing. But we see children, across lifespan. And the low vision or vision part, the difficulties are the barriers that we face is that, as Dr. Shalja pointed out, that how do we know whether it is because of the developmental delay? Is it because of the inherent disability the person carries, or is it acquired? So that's the same questions we begin with. Our investigations begin with the same questions. And I would say that our work starts where maybe you have ruled out all those things. So if the organicity is ruled out, then we say that maybe the intellectual disability or this is because of various psychological, etiological reasons. Yeah. So just setting the stage, you would know this, and I don't need to re-emphasize. However, this was sort of new to me, and while I was going through the literature, that what is the burden of disease in terms of when we talk about low vision. So about 2.2 billion people have near or distant vision impairment, and at least 1 billion of these vision impairment would have been prevented or is yet to be addressed. So that is something that is in our control. Only 17% of people with vision impairment due to cataract have received access to appropriate care. That's again a public health issue. everyone, if they live long enough, will experience at least one eye condition in their lifetime that will require appropriate care. So we count ourselves in. We take vision for granted, but without vision, we struggle to learn, to walk, to read, to participate in school, and to work. Just as we take breathing for granted or any sense organ for granted. So, whenever you interact with a client who has a patient who has a low vision, it comes with a lot of psychological sequelae. And the impact is not just on the person in terms of disease or biological impact, but personal impact. The personal impact, like young children with early onset irreversible severe vision impairment, can experience delayed motor, language, emotional, so on, with lifelong consequences. School age children with vision impairment can also experience lower levels of educational achievement. So, why this is so is because of the neuroplasticity, when there is an interference in one sense that helps us interact with the environment, and the stimulation should be there. If one of that is missing, then the developmental delays are not, if not global developmental delays, but it is acquired because of the barrier due to the sense organ that causes. Vision impairment severely impacts the quality of life among adult population, and adults with vision impairment can experience, of course, lower rates of employment and higher rates of depression and anxiety. In fact, the mental health problems are 2 to 3 times higher when adults or anybody suffers from low vision problems. In case of older adults, vision impairment can contribute to social isolation, difficulty walking, higher risk of falls, fractures, greater likelihood of early entry into nursing or care homes. So, from young children to adults to older adults. So, what is the psychological cost of vision loss? Can I ask the house, when you have interacted with so many patients, what do you think is the psychological cost, or can we just, or do we just even think about it when we are interacting with patient, or we just dismiss that part, or we just maybe think that this is not my domain to take care of, or does that question bother us?
Progressive inherited retinal disorder, suppose we see, because the age of onset is around 13, 14, 15. They've had a life in that point and they've gone to school, have every normal interaction. And at that time, we're counseling them that you have a progressive disorder and you might deteriorate visually. So the anxiety about future at that point, even a 15-year-old is deciding what kind of stream they want to get into, what do they want to do with their future, and all of that sort of dismantles. So we've seen that anxiety come off in the clinic.
Yeah, so that means that there is a loss of a functioning person, already fully functioning person. There's a loss of that. And there are psychological consequences of that awareness also. We'll discuss that. So the psychological cost of vision loss, vision loss is consistently ranked as one of the most feared health conditions. The psychological impact is grief process. Now, grief in terms of psychology has stages, has 5 to 6 stages. Is anyone aware of that?
Well,
Yes. So, yeah. So first of all, mourning the loss of function and independence. As I mentioned earlier, that adults with vision loss face double the rate of anxiety and depression compared to general population. Data says that 49.5% individuals with profound vision loss meet the criteria for depression. So hence it becomes a public health issue, which complicates the treatment and overall rehabilitation outcomes. We have talked about the depression is 2 to 3 times higher. Anxiety is fear of impending doom. Something bad will happen to me, something unknown and something so uncontrollable will happen with me, and I'm not prepared for that. So that is the difference between anxiety and depression. Anxiety Worrying about the progression of their condition and eventual total blindness, as you mentioned, mobility and safety, fear of falling, navigating unfamiliar environments or injury, and social interaction, anxiety about being a burden or how others perceive their disability can affect their self-esteem. Grief and mourning,
These are basically the 5 stages, no?
they are not exactly that, it is just,
हो गया.
not exactly those 5 stages by the book, but I have just picked these stages what makes sense in vision loss. So denial, of course, bargaining and mourning. Bargaining as in when someone dies, how we negotiate with the higher power. That why it happened
This
with
person, why not
this,
this
why not me,
person,
mujhe utha lete, the typicality of it. So that's negotiation. Anger and frustration, feeling intense frustration with functional limitations, and sometimes anger at the situation on health or healthcare providers, stress and hopelessness. And a perceived curtailed life leads to chronic stress and feelings of helplessness and hopelessness. Now, loss of independence and identity. We understand that it affects our autonomy and independence because we are not able to do our activities of daily living, and we are dependent on others. And finer skills like driving, managing finances, reading a mail, cooking, all of that becomes almost impossible, leading to a loss of independence. And altered self-concept. Who am I as a person? Or what am I capable of? Or am I capable of something substantial or meaningful? So person's identity is often tied to their abilities, being a housemaker, or going out and earning money for my family, or so all of this causes a sort of like it enhances the disability. The inability to perform these tasks can lead to low self-esteem and worthlessness or inadequacy, and these two are critical symptoms for depression as well, and fear of being a burden.
So this, sorry to interrupt. This is basically happens only with older patients who have been very active throughout their life, and then
Yeah.
suddenly there, is a vision loss, bilateral vision loss. Then usually they come up with the same thing that, I'm not able to drive, I'm not able to do my work, and I'm dependent on others, and that really actually kills them more than the disease itself.
Yeah, and then there would be loss to follow up if that hopelessness and worthlessness increases. It might also point in, carrying on with the treatment if there is no treatment. Or so
Commonly
follow-up
happens
will be
with those
good.
of our LHON patients.
Patients also,
Yeah.
yeah.
Young, they are earning, they are the sole bread maker for
Right.
the year, and then they suddenly deteriorates one eye after the other, and then they are in desperate trauma.
Yeah. And for young kids and adolescents, I would say that that's the stage where identity formation is happening or self-concept is developing. So that will not allow it to their personalities to develop age appropriately. So social and interpersonal impact is social isolation and loneliness, negative impact on relationships. Caregivers also face their own psychological toll, and the dynamics between the person with low vision and the support system fundamentally changes. Work and education, of course, we know that there are not equal opportunities, there is a difference between equality and equity for these people. And hence, all of this causes a compounding effect, which can then they can enter into a negative feedback loop where there is non-adherence to treatment because of mental health issues, depression or anxiety, and vicious cycle with stress, and maybe the vision rehabilitation. I don't know what in our country what kind of rehabilitation resources we really have.
There are, but limited, not every
Yeah,
place
limited.
has it, but at least we have it and we try to. But then, yeah, as you said, there are stages of these acceptance. No? So initially they won't go ahead with until they accept that now everything will not change or something will not increase, the vision will not increase. Then they tend to go ahead with low vision aid. So that acceptability comes very late and sometimes doesn't come at all. Because depending on a visual aid, they feel that then they have accepted that they are blind and they will not improve.
Social stigma is so high. Carrying a cane, people, they want that their neighbors should not know that we child or a young adult with low vision.
That is with any disability, basically. The stigma is with the various diseases also, not even just, and for disability, it is more pronounced. So, risk factors for mental health issues. It severity of vision loss, mild to moderate, can trigger distress due to functional difficulty. If there is any comorbid chronic condition like diabetes or any chronic condition that can exacerbate psychological distress. If there is any rapid onset, can be particularly traumatic, leading to acute psychological shock. Younger age have even higher risk of serious anxiety and depression compared to older adults, potentially disrupting career and life goals. Critical insight: psychological distress is often underdiagnosed in routine eye care settings. So, if
I want to share one of my patient who lost he had that retinal problem and he lost the vision, complete vision, first initially in one eye and then another eye. It was a hemangioblastoma and it's also involved the other systems also like the spine, the kidney and all. So he had parents already expired, but he had the siblings. So he was able to manage the businesses and all, even with he can't see because of his phone, and he was used to. What I remember, he used to that BlackBerry wala jo old model hota hai, because he was very used to typing and all that. So for him, it was like that. The sisters were like, I want him to get married, and he was like, I don't want to get married because I feel that I'm already a burden, but I can at least take care of myself. I don't know how will I take care of my family. So I think that in the long term, the loneliness is also one thing that
loneliness, yes,
yeah, even their family supports, but is they know that the burden feeling is too much. That
even if family is supportive, in our country there is, I mean, the social fabric and social structures are changing from collectivistic society to individualistic society and urban living and apartment livings where people are feeling more and more lonely. And given the disability, people tend to feel that even more. However, there is no arrangement, not I would say that no provision for older adults or people with disability by the system.
acceptance
I would say that the government policies are not so supportive or not readily available to support anybody with the disability, whether it's employment, whether it's resettlement, whether it's support care homes or halfway homes. So in all of this story, there is person at the center, but there are people who are caring for the person. They are caregivers. Now, whenever there is any sort of disability, be it vision or any sort of intellectual disability or mental disability, physical disability, the caregivers take the load of caring. And they are the ones who are not at the center, but share more burden. So they are the invisible patients. And in the routine care, we take them as fully functioning individuals who are also like us taking care of the patient. But the multidimensional strain that is put on them can cause psychological consequences with them also. And prevalence, there is substantial percentage that they experience stress and depression. There is very simple, very famous, common inventory that we can routinely do. That is caregiver burden inventory that has these three key components: time dependent, how much of their personal time is going in caring, and what is their own leisure time, or how much time they are able to devote on their work and employment. uh, Developmentally, are they feeling cut off from the world outside, cut off from the life stages and opportunities of their peers because they need to care for a patient? And emotional is, of course, feelings of guilt, resentment, or depression. So what happens is when we see the patient and the caregiver dyad, then the patient distress, if they experience any depression or anxiety or any psychological distress, there is increased dependence, increased caregiver burden, and because of high caregiver burden, there is burnout and depression in the caregiver, which decreases the quality of life and strained relationship. So there is relationship impact also. So hence, screening and supporting the caregivers is also an integral part to the patient's successful rehabilitation that we do. For any mental health disorder, our treatment focuses on caregivers equally as much as with the patient. Now, my last two slides here are that how do we, what can we do if there is all of this is present and we cannot dismiss or deny this reality? What can we do? So we can do a simple screening, like patient health questionnaire has two questions: PHQ, GAD. Again, general distress, anxiety, and depression. Two questions. We can just ask them routinely and see if they are what is their score like in every visit and follow-up appointments. If we feel that it is positive, then we can do PHQ 10 or GAD, like more items, WHO 5 items. So there are a lot of screening tools or rating scales that we can routinely ask. I'm sure that when you sit and talk to patient, you would be asking certain questions which these tools may be covering. So we can do it in a more scientific fashion. And normalizing what they're feeling, acknowledging the emotional difficulty of vision loss, validate their grief and fear, and establishing no healthcare system is working in silos. It should not work in silos. You can establish a referral care system or referral pathway for people with psychological sequelae, mental health care professionals around your area, and those who do low vision rehabilitation. I'm told that rehabilitation is an inherent service here as well. And then genetic counselors, they're available here. Basically, my last point here is that we cannot effectively treat the eye without addressing the mind. Then there are effective psychosocial strategies that we could do. Again, rehabilitation, OT, low vision specialist, and boosting their self-esteem or feelings of hopelessness and helplessness, or if the sadness is more than 2 weeks, then it qualifies for depression. So we can flag it up. Psychoeducation, counseling, adjustment counseling, or accommodation. Like you said that, suddenly there is a disability, or the person is not prepared for it, and there is a functional loss of fully functioning person. Then there is a passive grief that sets in, that I am not the same person I used to be yesterday. So they are passively grieving over the death of the person who he or she was earlier. So that passive grief we have to watch out for. So those the counseling related to the accommodation of a new life. Coping strategies like mindfulness, relaxation techniques, and problem solving skill training, especially useful for caregivers. We can create a support group for caregivers, and we can have a joint, peer support session or relaxation techniques or Yog Nidra that we often use it. And referral to support groups, connecting patient and caregivers with peers and to combat the social isolation.
basically empowering them, focusing on the residual vision and ability, not just the disability, whatever strengths still they have, let's focus on that. Yeah. So in your clinic, what you could maybe do is that you can prepare a standard protocol, a standard part of low vision care pathway, and you can have specific actions to your practice, developing a screening protocol, providing a list of mental health providers or support groups that specializes in low vision and handing it over to the patients and caregivers, recognize the caregiver distress, and then forming their own support group to provide the seamless integration to improve the functional outcomes in patients and caregivers both. Also, whenever we are not treating a disease, we are not treating a particular vision loss or disorder, we are seeing the patient as a whole person, so that invisible burden is also taken care of. So focus on caregivers is important.
Question is screener.
Which one?
That last, yeah, the 2 question is screener.
The screening protocol.
Screening protocol.
Yeah, I have, so you can devise it for your own patient population, that what can suit the best, like what can suit this cultural, in the cultural context of patients, the profile of patients coming here. Is there any, since it's a charitable hospital, so are there any mental health NGOs that are working so that they can go and talk to them, or who have the support groups free of cost service to them, or linking them to the nearest government hospital that have no bearing on, no burden as such for care. And so I have devised this. This is not given anywhere. I have devices that what you could possibly do. You can devise on your own. Linking rehabilitation services, linking support groups, linking mental health professionals. So the disability inherent in low vision is a function of the uncorrectable vision loss interfering with daily functional tasks, which is then compounded by inaccessibility of environment. So effective management requires not only clinical intervention, but also a robust rehabilitation and societal accommodation and destigmatizing the disease.
Thank you. Cut short because we start around 9 o'clock, so we were running a little bit late, but excellent lecture, Dr. Prerna. These aspects actually quite often we don't touch during our examination, and in fact, the moment the patient starts talking about these problems and all, we think it's taking our chair time, especially because we have a high volume OPD. So we tend to just ignore it and say, okay, ठीक हो जाएगा, अच्छा ठीक है, आप चल जाओ. Many times you don't even suggest because to go and meet a psychologist because there's again a stigma attached to even suggesting that. अरे आपको क्या लग रहा है कि मेरा दिमाग खराब हो रहा है या क्या हो रहा है करके ना. But that even now in India, it is not that really acceptable to patients or the caregivers. If you tell them, oh, there could be a psychological issue, I think there should be a better word for it to just suggest them not there's a psychological issue, because they immediately think about psychiatric issue. So how to break that thing to patients that
तो उनकी भाषा में हम जैसे अगर बात करते हैं पेशेंट से, तो हम आई थिंक आवर पेशेंट प्रोफाइल इज आल्सो सिमिलर, लाइक लोअर मिडिल सोशो स्टेटस. मन की समस्या है या उदासी एक बीमारी है, उसका इलाज है और बिना दवाइयों के ठीक हो सकता है, किसी से बात करके मन हल्का हो सकता है. बहुत सारी ऐसी बातें हो सकती हैं जो हम घर में नहीं एक दूसरे से बात कर सकते हैं, लेकिन हम किसी और से बात करें तो हमें हल्का महसूस होगा, अच्छा लगेगा. कुछ ऐसा समय जब हम बीमारी के बारे में ना सोच रहे हो, बीमारी के बारे में ना बात कर रहे हो. सो devise your own language which is culturally relevant is important. And also sometimes faith healers, if it is helpful for them to have any sort of spiritual counseling, or they go somewhere, it's all right unless and until, yeah, so we don't discourage that कि लेकिन हम ये बोलते हैं कि इसके साथ साथ आपको ये इलाज because then they will be lost to follow. They will not adhere. If we challenge their cultural context, they will not adhere.
I think Sonia is here. Sonia is a low vision expert. She's the head of the low vision department. So I'm sure many of the low vision patients would be facing, because most of them go to her for the low vision devices and all. Many take it, many don't take it. But then how do they face it? Sonia, are you around?